My name's Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and we're very pleased to have with us today Andrea Thomas, who is a psychologist with the Henry Ford Comprehensive Epilepsy Program. And Andrea, can you just introduce yourself? I know a lot of people know you already, but you can give kind of an overview of your experience working at Henry Ford and some of your clinical and research interests, and then also your experience with this topic. And before you get started, actually, someone just joined us. Who just joined us?
Marcia.
Hi, Marcia.
Oh, hey, Marcia.
Hi, who's this?
This is Andrea.
Andrea
is just about to introduce herself, so go ahead.
Okay. good timing, Marcia.
Okay.
I'm Andrea Thomas. As Russ said, I'm a psychologist with the Henry Ford Comprehensive Epilepsy Program. So I work right in the neurology department, and I've been doing that for the past 10 years. Prior to that, I was with the Epilepsy Foundation. Non-epileptic seizures have always been an area of interest for me. I'm also, I see a lot of people that have mood disorders, depression and anxiety, and a lot of people with post-traumatic stress disorder. And surprisingly enough, everything is kind of intertwined. There's a lot of overlap with all of those situations. And some of the research I've done has been in the area of non-epileptic seizures. And so it's just a very major issue with me, and probably the majority of people that I see have that diagnosis.
Okay, great. Well, let's start out with some definitions. First of all, can you explain what psychogenic non-epileptic seizures are, and also, importantly, what they aren't?
Well, that's good that you put it that way, because that's often how I try to approach it, with people, to tell them what they are and what they're not, because it can be very, very confusing. Psychogenic non-epileptic seizures, and sometimes you'll see PNES, is an abbreviated form, but we usually will just say non-epileptic seizures. They're behavioral events that appear very, very much like an epileptic seizure. In fact, to see one, unless you are a neurologist, well, and I have to qualify that too, unless you are an epileptologist who's had a lot of experience with non-epileptic seizures, it isn't always easy to tell just by seeing the seizure itself. Because just as with epilepsy, there are different kinds of non-epileptic seizures, and they mimic pretty much the same range of seizures as epilepsy. But they are not caused by electrical disruptions in the brain. So EEG testing doesn't show any kind of electrical disturbance associated with these typical spells. They're caused by stressful psychological experiences, emotional trauma, and that can be different for each individual person. Everybody's definition of trauma might be different, so what is traumatic for one person isn't going to be for someone else. But typically, there is some sort of major emotional issue going on.
Okay. And just so people are familiar with some of the other terms that are used, and unfortunately some of them are not appropriate terms, but some of the other terms that have been used or that may be used to describe these events.
Well, one of the most common is pseudo-seizure, which we do not use that term at all. Unfortunately, it is still widely used in other places by medical professionals. Pseudo anything implies something that isn't real, and there is nothing fake or phony about a non-epileptic seizure. A very, very small percentage of people would fake something like that. In all my years, I can count on one hand the number of people that might have been attempting to do that. So it's really very rare, but in the minds of some medical professionals, that is how they look at it, and the term is still used. But I always tell people, if someone uses that term, correct them. There is no pseudo seizure. They are non-epileptic seizures, and that's the only acceptable term used by comprehensive epilepsy programs around the country, or in any of the literature, the good literature that you read.
Right. I've even heard terms like hysterical seizures and things like that before. And I've seen some in the literature, like psychogenic non-epileptic events rather than seizures. So there are different terms, but the preferred term is psychogenic non-epileptic seizures, or PNES.
Absolutely.
Abbreviation. So although we'll be focusing on the psychogenic non-epileptic seizures, can you briefly explain what physiologic non-epileptic seizures are? Because that's another term you might hear when in reference to non-epileptic seizures.
Yeah, and there is a major distinction. I'm going to preface that by saying that when the diagnosis is made, a person is not given a diagnosis of non-epileptic seizures if there's anything questionable. So if there is any type of a medical basis for it, that's going to be explored, and it's going to be made very clear that there is something physiological, something biochemical involved. Some non-epileptic seizures can be caused by things like low blood sugar, like hypoglycemia, or very high blood sugar, migraine attacks, sometimes fainting spells, even severe infections or a high fever, can cause an event that looks like a seizure, and we find out that it's not epilepsy, but it is the result of something physical.
Right.
So then, of course, that has to be treated appropriately. Sometimes drugs, taking certain medications, certainly street drugs, but also some medications. One of the most common, there's an antibiotic by the name of Cipro that is very commonly used, and it can actually produce seizures. And some over-the-counter medications, some antihistamines, can also produce seizures. So if a seizure occurs as a result of something like that, it's different from the seizures that I might see someone for, because it's not a psychological basis for them. Sometimes when drugs are stopped suddenly, people will go into withdrawal seizures. And so those, because they're temporary, they're not going to continue to occur. Once the withdrawal is over, then people will, no longer continue to have them. Those might be called non-epileptic seizures, legitimately so. But again, they're not the psychogenic non-epileptic seizures.
Okay, great. So you talked a little bit already about what some of the possible causes, but can you go into a little more depth as to the common causes of psychogenic non-epileptic seizures, and then also who's most likely to experience them?
Well, we usually, once the diagnosis has been made, we may already know some background of the individual. But it's kind of assumed that there is something in their history, something in their past, or even in their in recent history that may have been very traumatic, caused high levels of anxiety, something that maybe is even too difficult for them to talk about. What happens is the body can only handle so much stress. We're all wired differently. So what one of us might consider a high level of stress, someone else might be able to tolerate, but then they too will reach their limit. And when the body has reached the point where it can no longer handle that level of stress, it converts it into some type of medical symptom. So the symptoms are very real. A seizure is a seizure. That's pretty much our philosophy when we're looking at this issue. Whether it's epilepsy or a non-epileptic seizure, when the seizure is happening, it's a very real event. But then at that point, we have to try to work with the patient and figure out what may have been the cause, for it to start. And it can be something that happened decades ago. And it just depends when the body reaches that upper limit, when it can no longer handle the stress, and then you'll develop some type of medical symptom.
Okay. Now, is it fairly uncommon for people to experience psychogenic non-epileptic seizures simply because of current stress, like if someone's going through a divorce or
yeah,
they're
that can be the case.
It's finals or that type of thing.
Okay,
so that
yeah, absolutely.
Okay.
Yeah, it isn't always a major trauma from the past. I've seen people who just have an accumulation of stresses in their lives, and everything it builds up to that certain level. It could be work-related. It can be too much pressure from school. It can be almost anything. Motor vehicle accidents. I've seen many people who develop non-epileptic seizures after a motor vehicle accident. And there have been some studies that have been done on that to indicate that can be a cause.
And you've mentioned post-traumatic stress disorder, anxiety disorders, depression. Are there other mental health issues that tend to be associated with psychogenic non-epileptic seizures?
I would say probably maybe post-traumatic stress more often than not, but otherwise nothing that's specifically related, but certainly we see a wide range of other issues like depression and anxiety, panic disorders. In fact, sometimes panic attacks are misdiagnosed as seizures,
right.
And then we find out that that's not the case.
Okay. So let's now talk a little bit about how psychogenic seizures relate to epilepsy. So I've read that about 15% of patients with psychogenic seizures also have epilepsy. But do you know what percentage of people with epilepsy also have psychogenic non-epileptic seizures? I've had a hard time finding that particular statistic.
Yeah, I mean it's pretty similar, 15 to 20%. So certainly some people can have both. Either way.
Right. Okay, and I've also read that anywhere from 10 to 40, or even as high as 80% of patients referred to comprehensive epilepsy programs actually have psychogenic non-epileptic seizures, and then also about 80% of patients with psychogenic seizures have been treated with anti-epileptic medication. So clearly misdiagnosis is common, and like you said, both ways, either psychogenic seizures being misdiagnosed as epilepsy or vice versa. So the gold standard for diagnosing psychogenic non-epileptic seizures is video EEG monitoring. Can you talk a little bit about how that's used? Yeah,
sure. Sometimes, as I said before, it's difficult to tell, and, people who have been diagnosed with epilepsy and then they come into the monitoring unit and they're told, well, that's not what it is, you don't have epilepsy, you're having non-epileptic seizures, they tend to become very upset and very angry. But you have to keep in mind that when you have the first seizure, you go to the doctor and you describe a seizure. And, monitoring is not something that's done routinely first thing. When someone describes a very clear-cut seizure, or someone that's with them that saw it says, well, this is what happens, the doctor's going to run some basic tests like an EEG. But an EEG can be normal and you can still have epilepsy. An EEG can be abnormal and you don't have epilepsy. It all depends what's happening during the seizure itself. And it's not that often that someone is hooked up to an EEG when they have their seizure. So even though the EEG is important, it isn't the only thing that you go by. So someone can be started on anticonvulsant medication because the doctor has to err on the side of caution and do the responsible thing and provide treatment. But as time goes on, if they're not responding to the medication, they may try a second one. But at some point, whether it's the amount of time that's gone by or the fact that, the seizures are maybe increasing despite the medications, at some point the doctor's going to have a suspicion that there's something else going on. And that's the time when admission to a monitoring unit will usually happen. And I would say that 40 to 50% of the patients that we see in our monitoring unit leave with a diagnosis of non-epileptic seizures. So it's much more common than people think.
Right.
Not always in the community, but certainly in a comprehensive epilepsy program, it's something that we see all the time.
Right.
So anyway, you asked about the monitoring unit. It is the gold standard simply because it's the only clear-cut way to ultimately make the distinction between the two, because you are hooked up to EEG and to a video monitor 24/7. So someone is monitoring constantly, so whatever is going on, typical episodes, even minor things, are going to be captured in on the video and during the EEG, and then the neurologist sits and goes through the two and looks at when the event button was pushed. Okay, someone indicated there was a seizure. Then they look at the EEG, and if there is a typical pattern of electrical disturbance that they expect to see with a seizure, then they know that's an epileptic event. If that is absent, then that particular seizure that is occurring was non-epileptic. So at the end of, it's usually a 5 to 10 days or 7 to 10 day stay in the monitoring unit. That's kind of the average time frame. If all of the episodes that have occurred during that time in the unit are non-epileptic, then we can feel fairly confident, and they've ruled out any medical problems, and we can feel pretty confident in giving that diagnosis.
Right. So you mentioned that basically the seizure itself, what's witnessed in terms of symptoms, doesn't have any corresponding EEG abnormalities. That's typically not, or that's typically a good sign that it's psychogenic non-epileptic seizures, but there are some exceptions, right?
Mm-hmm. Well, and, the one thing that we can't say with absolute certainty, no one can, when even giving the diagnosis, we can say everything that happened during your stay was non-epileptic, or X number of the seizures you had were non-epileptic. But even if they're all non-epileptic, we can't tell someone with absolute certainty that they would never have an epileptic event, because, we have to go by what we see. We're pretty certain that this is the case. And if everything that's seen during the admission is non-epileptic, then that's, that kind of reinforces that picture. But it is, we have had people that have had no epileptic seizures during their monitoring stay, but 6 months later, they've had one.
So I guess my point is that there's occasionally, it is possible that you can have an epileptic seizure that wouldn't show up on an EEG in rare cases, either because it's coming from somewhere deep that the
very deep in the brain, yes,
can't measure, or sometimes that there can be basically some artifact from the movement I've read, so that can make it hard to tell whether anything was going on. So, well,
the neurologist can tell the difference between muscle artifact and the seizure, the brainwave activity that indicates a seizure.
Oh, okay.
But there are also subclinical seizures that are sometimes, you can't tell by looking, nothing's really happening. The individual may not feel anything differently, but there can be, as you say, something occurring either very deep in the brain or it's not strong enough that it's, clearly indicated.
Right. Okay, so what are some other tools that can be used to diagnose psychogenic non-epileptic seizures? Obviously, patient history is really important. I know that I've read about serum prolactin levels. The thing I'm most interested in is if you could describe some of the distinctive features of psychogenic non-epileptic seizures that may help distinguish them in terms of the symptoms that you might witness during the seizure.
Sure. Well, first of all, the first, thing that will be noticed is if the seizures don't stop despite being on seizure medications. Now, I realize that many people with epilepsy also have an intractable disorder, and despite all the medications, they continue to have seizures. But the seizures are a little bit different in the case of non-epileptic seizures. Sometimes the movements are kind of erratic, whereas with epilepsy, the seizures are very, very similar. Most seizures that a patient has look very similar no matter when they have them. One issue that's really significant is the longer the seizure lasts, the more likely it is to be non-epileptic in nature. Epileptic seizures tend to be shorter, maybe a minute or two. It's not unusual for someone with non-epileptic seizures to say that their seizure went on for 30 minutes or an hour. If we know that there is a history of trauma, physical, emotional, sexual abuse, sometimes the loss of someone very close to you, being a witness to a tragic event, can cause something like that to develop. Non-epileptic seizures are often, people will have unusual posturing. For example, they'll arch their back. That's very common. There'll be side-to-side shaking of the head, banging the head against the wall, stuttering, crying. All of these are things that you just don't see that often with epileptic seizures. Okay. And sometimes in the medical history, we'll pick up on other conditions that, it may be psychogenic in nature, like chronic pain that is unresponsive to treatment because, pain is a very difficult thing to endure, and pain wears you down, and sometimes, it's to the point that, it coexists.
And what also I've heard about, do psychogenic seizures tend not to have a postictal period as well?
Yeah, they can. I've seen a lot of people, when the seizure is over, but they'll have a period where they're extremely fatigued, sometimes confused, like disoriented. I had someone that I saw on Monday who actually had multiple non-epileptic seizures back to back and was out for a good 30 minutes, and then when she came to, was very weak, very disoriented, had to be taken home. Her husband had to take her down in a wheelchair, so she was not able to walk on her own.
Okay.
But it was a non-epileptic event.
Right. Okay. So are there any... you've kind of touched on some of the biases that some doctors have and just the general public may have, but can you talk a little more about some of these tendencies among doctors regarding psychogenic non-epileptic seizures and epilepsy? Like, for instance, I've heard lots of stories of doctors assuming that a patient has psychogenic non-epileptic seizures simply because she's a woman and maybe her seizures are kind of atypical or not. They don't fit easily into a standard category of epileptic seizures. I've heard stories of doctors making diagnoses of psychogenic seizures based on a routine EEG being normal. Stories of people being told that their seizures were fake or just they were in your head, or just said, well, it's just kind of stress that's causing it. Just try not to have so much stress, and being sent away without any kind of treatment plan. Can you talk more about some of those biases and tendencies, and what patients can do to ensure that they're getting appropriate care?
Oh yeah, yes, I can go on that topic because it's a very sore point. I'll say at first though that in fairness to physicians, especially primary care physicians who really don't deal very much with that particular diagnosis, sometimes they just don't know enough about it. And like anything else, if you don't know a lot about it, then you need to defer to someone who does. But unfortunately, a lot of people do get a very negative reception from the medical community, doctors, nurses, psychiatrists, others in the mental health field. And this, it goes back to this use of the term pseudo-seizure. Well, there's nothing fake about it. But many assume that that's the case, so the minute that they know that it's non-epileptic or that it may be, they kind of, take a negative attitude towards the patient. Well, you can stop this. You're doing this, and they leave people with a very bad feeling that they in some way are causing the problem, that they have made it happen, that there's something they're doing, that they're making it up. Family members sometimes can then start to think, well, what's going on? Why are you doing this? Because you can't just tell someone, well, this isn't real, because it is real. A seizure is a seizure. It's just not epilepsy. But a person having a non-epileptic seizure has no control at that moment over it. They can't stop it. They can't do anything to change the situation until they get treatment. And they work with a treatment provider that knows how to approach it. So, again, in comprehensive epilepsy programs, you're going to have people who are very familiar with the situation, who know what they're dealing with, who understand that someone may have been through something very, very difficult, and you're going to get a very different picture. So, it's important, as with anything else, if you've been getting treatment for a long time and nothing's getting any better, you want to make sure that you're seeing someone that specializes in treating epilepsy. That's not to say that a neurologist isn't a good neurologist, but general neurologists have to be able to treat everything, whereas epileptologists treat only epilepsy, and so their training is more extensive. Their background is certainly more thorough, and they're much more likely to be familiar with this diagnosis than someone else. People get very angry when they're told that, this isn't real, it's all in your head. Well, I work with a neurologist who looks at people that say that and says, I'm a neurologist, everything I treat is in your head. And what he's doing is just making it clear that everything's important. It's not less important because it's not epilepsy. It's still a disabling condition. It's still something that has to be treated. And people have to be given the respect that they deserve because they're no more aware of what's going on than anyone else is. So they have to make sure that they're seeing someone that has knowledge of the diagnosis or is willing to learn enough about it that they can provide treatment.
Right. So for people who have both epilepsy and psychogenic non-epileptic seizures, is it important to be able to distinguish between both types of seizures? And if so, how can that be done?
Oh, it's extremely important because if you have both types of seizures, it's not unusual that you can't tell the difference initially because you've most likely been treated for epilepsy and your seizures have a certain pattern and that's what you know. You just had a seizure. So it becomes extremely important for us to help people to tell the difference between the two because the approach to treatment is going to be different. If you have epilepsy, we want to make sure that you're on the right medication to control your epilepsy. If you have non-epileptic seizures as well, then there's going to be some other things that we're going to be doing and recommending that are going to get those episodes under control. I try to help people distinguish between the two. Sometimes in the monitoring unit, they can show them their video monitoring and help them see, this was a non-epileptic, this was part of your epilepsy. I try to work with them to gain more awareness so that, they know which ones to target in terms of their efforts to get them under control. Medication for epilepsy is not going to control non-epileptic seizures typically. Medications like Keppra or, that kind of thing. Sometimes we will keep people on medications like Depakote or Lamictal because they are also mood stabilizers. So it's not unusual, when you come into the monitoring unit, one of the things that they do is decrease your anticonvulsant medications because they want to ensure that you're going to have a seizure. If it turns out that it's non-epileptic, they're not going to put you back on those medications because they're not going to help unless you need a mood stabilizer, in which case they may leave you on Lamictal or start you on Lamictal, something that's going to help with the non-epileptic seizure as well, simply because it has two uses. Many of the anti-epileptic drugs are helpful for other conditions as well.
With a psychogenic non-epileptic seizure, does the person typically have a memory of what happened during the seizure, or are they ever conscious during the seizure? 'Cause I'm wondering if that's a possible distinguishing factor.
Well, not always. At one time, one of the distinctive differences was that you lose consciousness when you have an epileptic seizure, and you don't with a non-epileptic event. But what happens? There's kind of a fine line when you talk about consciousness. For example, this patient that I saw a couple of days ago, her seizures were quite physical, quite violent. She was holding her breath. She doesn't have an awareness of what she's doing, what her movements are during that time. Is she unconscious? I think I could safely say that she is in such distress that she doesn't have an awareness of what's happening. So it's not unusual for someone to have a non-epileptic seizure and say, I don't remember a thing about it. Sometimes people will say, well, I could hear you, but I couldn't respond. Or I knew what was going on, but I couldn't do anything to stop it. So you know, it kind of runs the gamut. You can have different situations.
But for instance, someone having what looks like a tonic-clonic seizure and saying that they're aware during that seizure, that would be unlikely to be an epileptic seizure.
No, that would be, pretty much be a non-epileptic event.
Okay.
Mm-hmm.
So another thing that can be hard to distinguish is it can be difficult to explain the difference between an epileptic seizure that's triggered by stress and a psychogenic non-epileptic seizure where the underlying cause is stress. Can you talk a little bit more about that distinction? Because I often get calls from people saying, well, oh yeah, I have stress-related seizures. When I get stressed, I have a seizure. And it's hard to tell, are you talking about stress being a trigger for an epileptic seizure, or are you saying that stress is the underlying cause of your psychogenic non-epileptic seizures? So. Yeah.
Well, it is kind of a little bit of a slippery slope there, and I'll try to make the distinction without making it even more confusing. Well, first of all, we know that stress lowers the seizure threshold, both with epilepsy and with non-epileptic seizures. But certainly, if you have epilepsy, stress is going to put you at a much higher risk for having a seizure during a time of stress than at any other time. But it's not always going to happen. You're not always going to have a seizure with maybe, small to moderate amounts of stress. With a non-epileptic seizure, it's always stress-related. Okay, so if you have epilepsy, every seizure you have is not going to be triggered by stress, but stress can make the situation worse. Just as it worsens any other kind of medical condition. If you have allergies, if you have asthma, you're going to have flare-ups of problems because of the stress. But with non-epileptic seizures, stress is the underlying factor. It is the triggering factor. It's really the basis for everything that's happening. I don't know if that makes it clear or not.
That's a good way to distinguish. So, speaking of stress being a trigger for epileptic seizures, are there triggers or patterns or warnings for psychogenic non-epileptic seizures like there are for epileptic seizures? And is there any value in keeping a seizure diary for people with psychogenic non-epileptic seizures?
Oh, absolutely.
Some of the patterns or triggers.
Again, it gets a little confusing, but I've had many people refer to an aura before a non-epileptic seizure because, what is an aura? An aura is a feeling. It's a warning. And some people will have, they'll feel some anxiety. They may feel some nausea sometimes. They may get a headache. So, kind of similar things that happen. Again, if you're talking about a coexisting diagnosis, for example, someone who also has post-traumatic stress disorder. With post-traumatic stress disorder, you have a very high reaction to things like loud noises, strong smells, someone touching you, bright lights. All of those can be triggers for a high anxiety with PTSD, but they can also become triggers for a seizure. I have several people that I see who will go into a non-epileptic seizure if they smell like a strong smell, like a cleaning fluid, or something like that. That will trigger their seizure, or a very loud noise. So sometimes it's the coexisting emotional issue that also, becomes part of the triggering mechanism. So, you have to really, be sure of the whole picture.
Right. So, now that we've talked a lot about psychogenic non-epileptic seizures, what are some of the treatment options that are available, and how do the various treatments work, and how effective are they? And maybe if you can
actually, Bill, I'm just going to go.
Oh, sorry. Go ahead.
Mm-hmm. No, I was going to go back for a minute because you mentioned the seizure diary, and I did want to make mention about that. It is important, regardless of the type of seizure, because with epilepsy, you keep track of your seizures, and it helps the doctor to see what type of a seizure pattern you have, when you have them, how many you have. With non-epileptic seizures, what it will me to know is what may have been going on at the time that it occurred. People will bring in their diary and say, well, I had an argument with someone, and then 5 minutes later I had a seizure, or I was feeling very anxious about going someplace. I had to go to court, or I had an exam, or I had an interview. And, so we're able to tie it into something specific, and I'm able to help them to see the kinds of things that they need to work through. Whether it's certain things that they may hear, someone may talk about something and it may remind them of a past trauma, and that may trigger a seizure, or whether it's something that they're doing that they can maybe do differently, because there's going to be different lifestyle changes that people are going to make. And they're going to be different if you have epilepsy or if you have non-epileptic seizures. So, keeping track helps a therapist, it helps the doctor, and it helps the individual to know, where they need to make some changes in the future.
Right. And I imagine that relaxation techniques and general stress management techniques, which can be very helpful for people with epilepsy, can probably also be extremely helpful for people with psychogenic non-epileptic seizures.
Oh, very definitely. Everybody benefits from relaxation techniques, but certainly if you're dealing with, with the non-epileptic seizures, one of the first things that we always want to do, first of all, is make people aware of, if they have both, aware of the difference between the two. If they only have non-epileptic seizures, then we want them to be aware of the kinds of things that can trigger them. And sometimes before we can even work with the initial cause of it, because it may be something that happened 20 years ago that they're still, have never worked through, have never addressed, have repressed. But, we want to try to help the symptoms that are happening now. So a lot of times it's a matter of teaching relaxation techniques to kind of calm down what's going on at the moment before you even get into the historical issues of what may have been, the original cause of the non-epileptic seizures. There's different approaches.
The next question, so if you want to, whenever you're ready to start talking about some of the treatment options for psychogenic seizures, that would be great.
Mm-hmm. Okay. There's lots of different approaches to therapy. I usually get called in right after the diagnosis is made. Sometimes I'm able to go down and actually meet someone while they're still in the monitoring unit, and then we can kind of talk about the diagnosis, because the first step is always, my first question to people is always, how do you feel about the diagnosis? Because sometimes people have very mixed feelings. Sometimes they're very relieved that it's not epilepsy, and other times they're angry because they've been treated for epilepsy. or they're offended because they're still thinking that, oh, you think I'm making this up, you think I'm crazy, this is all in my head. So it's important to establish a rapport by working through the initial reaction to the diagnosis. And I try to help them understand what it is and what it isn't, like we started out with today. And then, why it might be happening, that it's not something that is their fault, that it is something that is treatable, they can get control. And if it's something that is related to a trauma, there's often a very strong hesitation or reluctance to even get into any of those issues, because maybe they've been able to deny it or ignore it for a very long time. But it's always important to come to terms with the things that have happened, because you can't move on without it. So it's not unusual for people to tell me, well, I've been in therapy. I've been in therapy with lots of different people. I was in therapy for years, and now this is happening now, or this is still happening. And it may be because the real basis for it was never addressed, especially if it's something as painful as some type of abuse. As human beings, we are always reluctant to talk about the things that are most hurtful and painful to us emotionally. But you never truly repress them. Sooner or later, it can be 20 or 30 years later, but it's going to surface. And at some point, in order to get better and to move on with your life, you have to deal with it. So depending on what the coexisting diagnosis is, because people very seldom just have a diagnosis of non-epileptic seizures and nothing else. If they're very depressed, then we're going to work on alleviating their depression. That might involve some medication. The same with anxiety. There may be an antidepressant or an anti-anxiety medication that is important for them to take to help through therapy. Because sometimes if you're severely depressed or highly anxious, you can't benefit from therapy as much until you're able to kind of at least take the edge off things. And then there's, with post-traumatic stress disorder, that may also include depression and anxiety. And so then, there are different approaches. With post-traumatic stress disorder, we may do something called exposure therapy. Every therapist actually has their own approach. It all depends on what they were taught, what era they were taught in. If you're old school, as I am, I still prefer the talk therapy. I also do some cognitive behavioral therapy. CBT is a very, very common practice today for a couple of reasons. The approach is very specific. You try to help people change their negative ways of thinking about things. You try to point out to them that they have negative ways of looking at things. Because, what we think influences how we feel. But insurance companies like CBT, because it's cheaper, because there's a limited number of sessions, and so a lot of therapists practice CBT only, because that's, kind of the going trend. But I personally, I try to suit it to the individual. So I'm going to use a variety of techniques. I use some CBT techniques. I always use relaxation techniques. But I also, work through the issues by, talking about them when the individual is ready to talk about them. So, there's different things. Now, you will hear people talk about some kind of controversial approaches like EMDR, which is eye movement desensitization and reprocessing. I'm not saying there's anything wrong with it. It's not something we practice here or that you will find in a lot of hospitals. You'll tend to find that more in private practice groups because it hasn't totally been proven that it's effective, for everyone. But CBT and talk therapy are pretty much the most common.
Right. So do epileptologists tend to work well with mental health professionals? Meaning, do they usually, at most comprehensive epilepsy centers, is there usually a referral network, basically, where if an epileptologist identifies a patient as having psychogenic non-epileptic seizures, do they typically have someone that they can refer to, or is it kind of like you just need to find, you're on your own and you need to find someone that has that experience? Because I know a lot of people often ask, how do I find a psychotherapist or a counselor or psychologist who has specific experience with psychogenic non-epileptic seizures? And there may not be that many out there. I know of you, obviously, but are there many others out there? And do epileptologists tend to know about them and refer to them?
Well, it typically in a comprehensive epilepsy program, and there are several around the country. There's at Rush Presbyterian in Chicago, and at Stanford, in Miami, at Brown in Rhode Island. You have epilepsy programs where the epileptologists are very, very much involved with the mental health side of it, because once they've made the diagnosis, they need to be able to, as you pointed out, to refer to someone who also understands the diagnosis. The biggest problem is that in the community, because I didn't learn about non-epileptic seizures when I was a psychologist in training. The first time I ever heard about it was when I was already in the field. And that's the case with most professionals. The most you're going to learn about it is through an epilepsy program, because it's so common to see someone with that diagnosis within those programs. I would say that outside of a comprehensive epilepsy program, it all depends on the neurologist. I've had people make referrals to me simply because they knew me through someone else that saw me, so it's sort of like word of mouth. Unfortunately, a lot of the time, once a diagnosis is made, the doctor will say, you know what, it's not epilepsy, you don't need to see me anymore, you need to go find a shrink, or you need to get into therapy. But they don't give someone direction. And so people call around, and as soon as they say, I have non-epileptic seizures, they're likely to get a response of like, what's that? So it is difficult if you live somewhere where you're not close to a program that has all of that training and understanding. So you have to, kind of inquire. We have booklets that we give out that I encourage people to take to their doctors. Take this to your therapist. I've had therapists call me and say, well, you know what, I read that, but I'm not comfortable dealing with it, so, what should I do? So it really depends.
Right. So
but you're in the best hands if you're in a program, an epilepsy program.
Right. I know the Michigan Psychological Association website has a tool where you can search for psychologists based on their particular specialties, areas of specialty, and I'm just wondering if, for instance, searching for a psychologist who specializes in post-traumatic stress disorder might be a good option. If you
Sure.
I know they don't have psychogenic non-epileptic seizures listed as one
no,
of
they
the
don't.
topics, but would that be a good proxy, maybe, or something?
That would, or when I said earlier that once the body becomes overwhelmed with stress, it converts the stress into a physical symptom. So a lot of times the other diagnosis that people will get is conversion disorder. And a conversion disorder is, it usually involves a problem in the nervous system. And it can be a seizure, it can be pain, it can be a loss of vision, inability to walk. There is no physical basis for the problem. It is, again, a psychological trigger. So some therapists are familiar with dealing with conversion disorders, and if they know that, that it's a similar, kind of problem, then they can handle that. So that might be something else to look under.
Well, we have about half an hour left, and I wanted to open it up for questions or comments. If anyone has a question for Andrea or an experience that you want to share about maybe being misdiagnosed and how you dealt with that, that would all be very helpful to us. So who wants to get it started?
My name is Marissa, and I've been monitored twice, and I've been diagnosed with having both. My first monitoring was back in 2001, and then the second was in 2005. And both times I was in the hospital for 10 days and monitored my seizure. So it was diagnosed that I have both. And I have taken within all of these years, I've taken several kind of medications. You had made mention of the Keppra and Lamictal. I've taken Tegretol, and a lot of that did not help. Right now I'm on Dilantin, and seeing my neurologist every 4 to 6 months. And at one point, my doctor did make it seem like I was making it up. Mm-hmm. And that did make me feel uncomfortable. Sure. Because I know what I felt and was going through. So that did kind of bother me, and I was kind of wondering if I should find someone else. So, go ahead.
Yeah, I can't tell you, not to continue to see your doctor, but, you are part of the group of 15 to 20% of people who have both epilepsy and non-epileptic seizures. Now, the Dilantin would be prescribed for your epilepsy. It wouldn't help at all with your non-epileptic seizures. And it's unfortunate that you experienced what so many do, being made to feel that it was your fault. Because, of course, you know what you go through. One of the other things that you find in some of the older literature is that people never injure themselves when they have a non-epileptic seizure. But I would hesitate to show that to my patients who have dislocated their shoulder or come in with bruises on their face because they fell to the ground and injured themselves. So, something like that happens. You're only going to get resentful if somebody tells you that, you don't have to do that. You could stop it.
Yes.
Yeah. But whether or not you see someone else, that has to be your decision. Are you being treated by a neurologist?
Yes.
Okay. Well, what about your non-epileptic seizures?
Well, as you had described, I experience a lot of the non-epileptic seizures. When I get into bright lights and the loud noises, I experience a seizure. Mm-hmm. And when you were talking about the memory, and I've been sitting up taking notes. I take notes. I take a lot of notes about the memory. I've experienced both epileptic and non-epileptic. I've also had to do a diary.
Okay, good.
So I keep up with, and I've also, about 3-4 years ago, my neurologist, I went through a study for a year and a half, and with this nurse, this one particular nurse, and they gave me a booklet, and I would write down what was happening with my seizure, in my environment, how I felt, what I ate, and all of that. So for about a year and a half. So, and they gave me some medication, but it was they didn't tell me whether it was a regular pain, not a pain, but a regular pill for the epilepsy, or if it was just a plain pill.
Oh, you were in a drug study. Okay.
Yes.
Okay, yeah.
So,
well, one of the reasons why it's so important to tell the difference between the two is that what often happens is, like with the monitoring, we'll find that a person, their epilepsy is actually well controlled, and it's their non-epileptic seizures that we need to focus on. So sometimes, there's a different approach to each one, so it's important to know, how many of your seizures are one or the other. It may be that you're not having any epileptic seizures. You have epilepsy, but those seizures are controlled, and it's the non-epileptic seizures that really need to be addressed. And, that's where therapy and, other kinds of medications are going to help.
Okay.
So you need to maybe talk to your doctor about, have him explain to you which is which. What are your epileptic seizures like versus your non-epileptic seizures.
Okay, I will. And I appreciate all of this.
I'm sorry, are you seeing a mental health professional as well?
No,
Okay.
just a neurologist.
Okay, you really should.
Yeah.
Yeah, you really should.
Okay.
Because that will help you to deal with the stress that may be triggering it. It's stressful just having the episodes themselves, but if you can work with a therapist, then they may help you to get your non-epileptic seizures under control.
Okay. Well, I really appreciate all of this information because, and I've started having it since May of 1999.
Oh, my goodness.
And the doctor had never sat down and talked to me quite like this. So I'm starting to feel a whole lot better about what's going on. But I thank you.
Good.
You're very welcome.
Okay.
Does anyone else have any questions or comments?
Nope.
Yes, this is Matt. And you were saying that non-epileptic seizures could last an hour.
Yeah, the longer because an epileptic seizure is actually very brief. Now, sometimes people feel it lasts longer because they are so tired after, or they may fall asleep, and that may last. But the seizure itself lasts only a couple of minutes. But non-epileptic seizure activity can go on and on and on, and that's when we start to really kind of question what's happening when someone says that it was a very long episode.
Well, because I had surgery 2 years ago, almost 2 years ago, and in the last, say, 9 months, I've had 3 seizures, and one lasted for probably an hour and a half to 2 hours.
Oh, my goodness.
And I was a cowboy, they were saying.
What do you mean?
Well, I was jumping up and down like I'm a cowboy. I was out west, and I was riding a horse, and I was just saying, well, I'm a cowboy, and going to fight the Indians, and going like that, something like that.
Well, Matthew, I would discuss that with your neurologist, because that may be something that they would want to look into. Usually when the seizure lasts a long time, what happens right after the seizure stops is the post-ictal period. And that's usually when people are very, very subdued, they're very tired, they may be sleeping, they may have a headache, they'll have other kinds of physical responses. But what you're describing might be something that you want to talk to the neurologist about, and have someone with you that can give a description of that, because that may be something important to know. And
then another one, I just you were saying about medication.
Mm-hmm.
The other one that I remember was I had the flu, and my Dilantin level was really down.
Mm-hmm.
And they said that I had a seizure. And
were you on antibiotics?
No.
Okay.
I was just on my seizure medicine.
But it sounds like maybe the level dropped.
The level dropped, yeah.
Yeah.
They said my Dilantin was busting up here, but I had Lamictal and Xanogram too with me.
Mm-hmm.
But my Dilantin level went from say 10 to 4.
Ah, okay. So your system went through something there, and that, could have put you at greater risk to have a seizure.
So would that be a...
No, that would be an epileptic. I'm pretty sure that would be an epileptic seizure, simply because your medication level had dropped.
So that would be none.
No, that was probably epileptic. The one you described a few minutes ago when you said that you were jumping around, and that's the one I think you should talk to the doctor about.
Okay.
Okay, because that might be a little bit different than anything you've described before.
Okay, but the medicine would be epileptic seizure.
Most likely, when people have if they have too much in their system and they're toxic, or they don't have enough in their system, a lot of times that puts them at risk to have a seizure. Because all of the medications have a therapeutic range, and it's important. Although that can vary from one person to the other, but a drop like that from 10 to 4, if that happened over a short space of time, that could have put you at greater risk.
Okay. Thank you.
And just one thing to mention, you talked about psychogenic non-epileptic seizures possibly lasting for a long time. The exception for epileptic seizures is status epilepticus, which is...
Oh, absolutely,
right,
yeah.
There can be epileptic seizures that last for half an hour or more, and that's because it is an epileptic seizure, and that's referred to as status epilepticus, and that is a medical emergency. So that kind of brings up a good question. If someone has both epileptic and non-epileptic seizures, that's another reason why it's really important to tell the difference between them, because if you have psychogenic seizures that, let's say, typically last for half an hour, and you've also had maybe status epilepticus in the past, that it would be really important to tell the difference so you know whether or not to seek medical attention.
Oh, extremely, because, certainly with status epilepticus, it is one seizure after another, after another, after another. There is no break, and that's why it becomes so critical. But with when I say a non-epileptic seizure lasts can last an hour and a half, there's something going on almost the whole time. The person is not accessible. Maybe they're not making sense. Maybe they're in and out of, saying things that don't make sense or doing things. And, I mentioned some of the other things like the head banging or the side-to-side head movements and the stuttering. If things like that continue on for an hour, then that most likely is a non-epileptic seizure. But with epilepsy, the actual seizure activity can end after a very short time, but the disorientation and everything that follows is the aftermath. It's the post-ictal period. But that was a good point to bring up, Russ, about status epilepticus. Although we have had people with non-epileptic status as well.
Right.
They just continue to have non-epileptic seizures all day long.
Right. So again, that's another reason to talk to your doctor about distinguishing between the two, because one of them is a medical emergency. A continuous epileptic seizures could result in brain injury or even death. So that needs to be
Absolutely.
Okay. So other questions or comments?
I have one. My memory has always been bad in that my focus is no good, and so my mind wanders. And I've always wondered if that has anything to do, with the trauma that I had in the past.
You mean an emotional trauma?
Yeah, and it's strange. My brain, part of it, in terms of my feelings, that's pretty good. So I remember things that hurt me, but my focus is so bad, I don't remember basic things. I mean, basic things, yeah, but events.
Well, there's a lot of reasons for memory issues. First of all, people with epilepsy a higher percentage of people have difficulty with memory anyway than the general population. But when it comes to stress, what I hear from people, and I hear that a lot from my patients, I can't focus, I can't remember. I'd walk into a room. A fellow told me last week that he walked into the room and he said, I tried to put the light on, it was already on, and then he said, I couldn't remember why I went into the room in the first place. But we know that stress affects a person's cognitive skills, and memory is one of the first things that becomes affected. If you have a lot of things going on, not necessarily just related to the trauma, but that on top of other things going on, maybe you just are really, really busy, or you have a lot of worries, or other people that you're trying to deal with, you can get to the point where your brain is basically in overload, and when that happens, it can literally shut down. Something's got to give. We are constantly being bombarded by hundreds of thousands of bits of information from all areas, sight, sound, touch, everything. And for the most part, we filter that pretty well. But when you are emotionally overwhelmed, that filter doesn't work. And so, it's not at all unusual for people to say that they're noticing problems with their memory. Again, I would talk to your neurologist. He could arrange to have some testing to determine if there really is a memory problem or if it is due to emotional stress.
Well, can that ever get better?
Oh, sure. If you learn to deal with the stress, you're going to learn to focus better. People who have had past trauma, who may actually have post-traumatic stress disorder, oftentimes complain of an inability to remember things or to focus their attention. But again, working with a therapist, you can learn to do that. You can learn to deal with the stress, and that will improve the memory.
Okay. Well, even before I had brain surgery, I was in Europe for 8 months, and I think I remember one event.
Really?
And that was, it's always been bad.
Okay, and it may be that you do have some memory problems that are related to, did you have brain surgery?
Yes, but it was before my brain surgery.
Oh, this was even before your brain surgery. Well, in that case, there's a possibility that it could be related to the past trauma, but it has worsened because of other things that have happened, physically, like the surgery.
Okay. Thanks.
Other questions? Got about 10 minutes left.
Yeah, Russ?
Yep.
This is Greg Schultz.
Hi.
If a person gives you a hard time in life, that causes stress too, right?
Oh, certainly, yeah. A lot of stress can come from relationships or even close relationships. Almost particularly close relationships can cause a lot of stress.
Oh, yeah.
Right.
Mm-hmm. One thing to keep in mind is that we can't change other people. We can only change how we react to them.
Yeah.
You know, and that's what you always have to work on, is how you respond to the stressor. Because a lot of times we can't eliminate the stress in our lives. It's just there. But we can change how we respond to it.
Mm-hmm.
Well, see, what if that person if they want you to do something, but you don't want to do it? What do you do?
Well, you have free will. I mean, you can refuse to do something that you don't want to do or you don't feel is right for you to do. I mean, you have that right. You have to know that you have the right to say no.
Mm-hmm.
There's also, assertiveness training is something that can help with stress too, because sometimes people have a hard time, standing up against people who are putting demands on them, and sometimes you can learn more how to be assertive, how to make your opinions known, and how to make your preferences known. So that could be another thing that might be helpful.
Okay, thanks.
I have another question that was, or actually more like a comment. My auras, I started to get blackouts when I was about 10, and for years it was more like the pain of the world. Especially when I heard an ambulance, I would go into a blackout. So is that necessarily symbolic or not symbolic, but of what it could be about, the seizures?
I mean, it could be and it may not be. Was it the intensity of the sound? Was it the actual sound itself that reminded you? Did you have a bad experience, or did you have a lot of crises where you had to ride in an ambulance?
It was the pain of the world that I felt when I heard it.
Really?
Just like horrified, yeah. Mm-hmm. And I think I was taken to the hospital at a young age, and nothing was wrong.
Yeah. Well, I would say, I can't say for certain, but I would say that certainly it could be, it could have been an emotional trigger.
Mm-hmm. Okay. Thanks.
Okay. Other questions? Particularly anyone else who hasn't had a chance to ask a question? Anyone?
I have a question.
Yeah, go ahead.
Because I take a variety of medicines, the side effects of the medicines make me drowsy. And then when I do have my seizures, I have a variety of seizures also. So wouldn't that mean that I would need more time to recover, because I have a variety of seizures, not just grand mal or partials, but a combination of a variety of seizures?
Well, everybody's recovery time can be different.
Yes.
Some people can come out of a seizure and just continue on with what they were doing, and for others it could be till the next day before they really feel fully, aware and able to carry on.
Did you have a further question there, Marcia, or?
Just to make, some people have a misconception. I think everybody just thinks about grand mal seizures, and when I try to explain to them that there are a variety of other seizures, they have a misconception about epilepsy.
Mm-hmm.
Right.
Well, I think that's because for a lot of people, their only experience is hearing about a grand mal seizure, or if you watch television and they portray someone having a seizure, that's what it's going to be. And if they don't have any other knowledge, they're ignorant of the whole picture, then they're going to have a very narrow view.
Yeah.
So you help them by explaining to them that that's not the case.
Okay.
And I find that it's very important. I've learned in the past years it's very important for our family and the people close to us to learn about what's happening and to be understanding. I have a daughter, one of my twins that stay with me, and she knows what's going on. And when I might have a petite seizure, and when she's here, you know, she'll ask me, you know, well, are you feeling seizure-ish? And I'll explain what's happening. So since this conversation, later on this evening, I'm going to talk with her and share with her what I've learned so far.
Oh, good.
And I have 4 daughters, and so that they can be able to know what's happening with me and the people who are around me a lot.
Oh, that's a good idea.
Yeah.
And there's still a lot of stigma and misunderstanding related to epilepsy, and maybe even more so related to psychogenic nonepileptic seizures. So it can be challenging sometimes getting the support of your family because of those misconceptions.
Yes.
Russ?
Yeah.
In that regard, could I say something? My name's Christy, and my initial interest in this was both clinically and also with my brother. And this was in the 1990s during the AIDS epidemic height. And at that time, the Epilepsy Society in our area, which was Minneapolis, was very unwelcoming to any AIDS patients being a part of their epilepsy, saying that they had epilepsy. I'd like to point out that classifications in medicine ultimately are for purposes of treatment. And at that time, they had epilepsy and they had pseudo-seizures. And that was because there was no way to treat and then no way to measure a lot of the AIDS patients. There were not physiological non-epileptic seizures. That wasn't a classification. The distinction between epileptic seizures and psychogenic and physiological non-epileptic seizures is ultimately saying that there's no electrical disturbance being measured. And that's, I think, very important for all patients to remember. It certainly has been over the years for my brother. Whether medications work is not definitive because medications are notoriously variant among individuals, not within the so-called norm. Surrounding stress is not definitive. Stresses are always present, so the triggers themselves are ultimately defined by whether or not they can be measured on EEG, and whether or not it results in a seizure that's measurable. The typical muscular distinctions that we recognize and observe are not definitive. Auras, timing of post-ictal periods. So I'd just like to very much say, very realistically, it can be said that everything ultimately is physical, whether on a gross scale or on a cellular level. And just like the psychiatric categories routinely change to reflect this, like schizophrenia is now looked at differently because they can have chemical treatment. EEG and use of EEG equipment has increased in sensitivity, and it has resulted, for instance, in recognition of middle brain seizures. So it's very important, I think, for professionals and the public, everyone, to remember that the difference between whether seizures are classified as epileptic or non-epileptic in any definition is reliant on the sensitivity of EEG equipment.
That's really important. Right. Thanks for sharing that. And I think that brings up another question I was going to ask is related to frontal lobe epilepsy, because that's another thing I've read about is that frontal lobe epilepsy, because the seizures can be fairly unusual and not typical, and neurologists may be less familiar with them, and primary care physicians may be less familiar with them. They often can be misdiagnosed as psychogenic nonepileptic seizures. So that's again where the importance of good high-quality video EEG monitoring and comprehensive epilepsy centers and epileptologists is really important, so that you can distinguish between those more complicated cases, like where someone has frontal lobe epilepsy, or even, let's say someone has frontal lobe epilepsy and psychogenic seizures. So it can get really complicated, and that's why you need specialists to be able to distinguish.
The bottom line is that there can't be a diagnosis of non-epileptic seizures without a stay in a monitoring unit, because that is the gold standard.
Right.
You can't tell by just seeing the event. You can't assume anything. So the monitoring unit becomes the only way to make that determination.
I think you brought up another good point, Christy, in that all conditions, whether they be called mental health conditions or mental illness or physical conditions, all conditions are physical in nature. So sometimes the distinction between the neurological conditions and mental illness is somewhat arbitrary because it's all physical. It's all related to brain function. So I think if we can get to a point where we view all conditions as physical and as having a physical cause, I think that can get us beyond some of the stigma. Okay, any other questions? We have just 1 minute or so. Any last questions? Okay, well, I want to thank everyone for... Oh, go ahead. Did you have a question?
Yeah, this is Matt.
Yeah.
You said something about CBT.
Mm-hmm.
What is
cognitive behavioral therapy?
Okay, thank you.
Mm-hmm.
Okay, well, Andrea, I want to thank you very much for this very enlightening discussion, and thanks everyone for joining us today. And if anyone has any follow-up questions, you can always email or call me. And I know Andrea is very helpful. If there's a question I can't answer, I can always drop her an email, and she'd be happy to help as well.
Certainly.
So, okay, thanks everyone.
And thank you.
Thank you.
You're welcome.